Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much everything else which is infectious disease or infection prevention related. This is the week of December 11th, and as we speak, respiratory virus season continues to be out there. One of the questioners asked about what we're seeing out there, so more about that in just a little bit. We're also, unfortunately, seeing a mini surge of SARS coronavirus 2 or COVID-19, and again, we'll sort of talk about that in just a second as well. The first question, however, very appropriately, has to do with the very newly released 2024 immunization schedule. This comes to us hot off the press from CDC, and if you're looking for it, you can access that through cdc.gov and or just search 2024 immunization schedule, and you'll get a nice PDF of what are the current recommendations based on ages, etc., and so forth. The questioner, however, asks about this new schedule. What are the changes for kids and adolescents that we should note or be aware of? And that there are a couple, no great earth-shattering changes, importantly, but certainly enough to sort of mention here briefly. The first has to do with some of the new vaccine products that have been licensed, approved, etc., and so forth. Chief among those are the new pneumococcal conjugate vaccines, and again, there are two that have been approved. One is the 15-valent with Merck, and the other is the Prevnar 20. And so you can look to see those entering and replacing the previous Prevnar 13, which is the pre-existing conjugate vaccine type. As well, you can look for changes in addition of the monkeypox vaccine for adolescents, at least with risk factors, most especially those participating in high-risk unprotected intercourse and or would travel to recently to the Democratic Republic of Congo, Uganda, and several other places in Africa. You could also look to see addition of information and recommendations for the RSV monoclonal antibody, nirsevimab or Beyfortus for those who prefer the product name, as well as a comment on RSV vaccine for pregnant women in their 32 to 36 weeks of gestational age group. And then finally, replacement for meningococcal vaccine going from the current quadrivalent meningococcal vaccine to the 5-valent, which now includes type B, and this starts to replace quadrivalent meningococcal vaccine and the meninge type B vaccines out there, mostly for modes or ease and convenience of administering to our high-risk adolescents about to become college freshmen and high-risk infants who may be asplenic or immunocompromised, etc. So those are the general notes about changes to look for. Certainly you can look for new information with the updated COVID-19 vaccine products, those being especially from Moderna and Pfizer, and with the new vaccines, which either are boosters for those previously vaccinated or the primary series. And we actually discussed that in some length in the last podcast after Thanksgiving. So look for that. HPV vaccine, just some clarifications about additional doses that may or may not be recommended for those who have completed a prior HPV vaccine series. Influenza vaccination, and this we've also talked about in this podcast previously. The major change is that everybody with a capital E through Y who is 6 months of age and older can and should get vaccinated with influenza vaccine, including those who are egg or ovalbumin allergic, because there are now sufficient products on the market which can be safely administered to those individuals who do have ovalbumin sensitivity. So this is a significant change in that everybody deserves and should be immunized against influenza A and B with the current quadrivalent vaccine products. Keeping in mind that those are inactivated influenza vaccines, there is this year also the live attenuated influenza vaccine indicated for age 2 and up. So all those they're well commented on in the vaccine schedule. Otherwise, a lot of this is otherwise just clarification, confirmation about what is out there, including some appendices and special notes for catch-up vaccine schedules, because this is always sort of a shifting target, who got what, where, when, and how we can do an effective catch-up. So those are the major changes to note. Again, I think that the big ones are the changeover of the pneumococcal and the meningococcal vaccine products, replacing prior recommendations just with newly approved products out there, and then the influenza vaccine updates as well. So thank you for that schedule. Again, please do feel free to go online and download that PDF file and or print out the pertinent amounts for your clinic settings. Next question. With flu and RSV cases on the rise, is COVID still causing the majority of hospitalizations in children, or has that shifted to a different respiratory disease? Well, it is. There are certainly still cases of COVID-19 with the newer sub-variants of Omicron, and those continue to precipitate at least sick visits. However, a majority of the patients being admitted, if they happen to have COVID, also have other things as well, whether it's a unrelated disease process, secondary infection, or co-infection. And certainly, as we now are coming up on halfway through December, in the rest of the country, for those of you tuning in from outside of Arizona, you certainly have seen a ton of RSV and are now seeing increases in influenza A and B as RSV seems to have peaked. And in some parts of the country, especially the north and southeast, the RSV numbers are starting to decrease while influenza continues to increase. Here in Arizona, it is still true that we're seeing a fair amount of RSV and other viruses causing bronchiolitis, and that SARS coronavirus 2 or COVID-19 typically is a secondary or a co-infection. We are starting to see continued gradual increases in influenza A to a large extent and some influenza B cases. But RSV continues to be the principal contributor to hospitalizations, oxygen needs, respiratory management, etc. And I think, at least in Arizona, we can anticipate those trends to continue. RSV will remain quite prevalent for at least the next several weeks, while influenza starts to come up. And ultimately, as we get into the new year, we'll probably have a more prominent number of cases with influenza as RSV plateaus and may, fingers crossed, start to decrease. So far, and that this is reported nationally, we have not encountered the overwhelming sheer numbers of RSV disease and admissions and ED visits, etc., that we encountered in the completely unexpected, late summer, early fall surge. And so all indications are that this is a more typical year compared to what we've experienced for the last 3 or 4 years of the pandemic. Next question. I've read that Ohio is currently experiencing a pediatric outbreak of pneumonia. What is contributing to this recent outbreak, and do we think that this is a trend we may see in Arizona? So what the questioner is referencing is, unfortunately, the China white lung syndrome, and I'm just sort of using the term which has been established by the media. And in fact, it is not any one specific pathogen, and this is true in Ohio as well as other parts of the country that are starting to see this emerge. It is a collection of RSV, influenza, adenovirus, and mycoplasma, and that is true in China, where this cluster was first noted with great concern, as you can imagine, by the media, not so much anybody else, but the media. And then Ohio, and a specific county in Ohio, it first experienced a cluster of such infections here in the United States, and now other parts of the country as well. So it is still true, and the CDC, and you can actually see a reference to this in the most recent MMWR, it is still true that this is still a hodgepodge of respiratory viruses and mycoplasma contributing to this. The white lung or severe pneumonia description really comes from the fact that these are patients who just are very sick, as we certainly have all experienced with any of those respiratory infections. But these are patients who, for a variety of reasons, especially including social distancing, etc., for the last 3 or 4 years, have not been exposed significantly to those respiratory viruses and thus do not have a significantly robust immune response. So they're getting a higher viral or infectious load, they're getting a higher degree of immune reaction, and thus a much higher amount of pulmonary parenchymal disease contributing to the so-called whiteout on the chest radiographs. So there's no magic to this, it's not a new pathogen, it's not anything new that we need to worry about, but just to understand that some patients, as always happens, are going to be a heck of a lot sicker, especially if they've been living in a sheltered environment for whatever reason. So will we see this in Arizona? Sure. Yes, of course. I would expect so. I don't know that we'll see clusters of cases, and there's still not full information coming to us from our colleagues in Ohio in that one specific county. The suspicion is that there may have been a focal segment of the population that may have been even more at risk and less immunoprotected against some of those viruses through very effective sheltering or living in a closed-in community. So we can certainly anticipate individual or discrete patients here in Arizona, but there were no predictions and no anticipations of general clusters or outbreaks of the so-called severe pneumonia or white lung syndrome here in Arizona. So this is also yet still a fairly newly emerging trend, and I guess it remains to be seen if it truly will emerge further, or if this is a cluster of cases that, due to the intense scrutiny placed upon our colleagues and families in China, that has just risen to much more national attention here stateside than might otherwise normally occur. So stay tuned for more. I'm sure we'll be seeing a lot more in terms of epidemiology and perhaps risk factors. And then the last question, that this may be a shorter podcast, but hey, it's holiday season. We all have lots of things on our plate and we're busy. But the last question goes back to COVID-19 and is asking about the current COVID-19 or SARS-CoV-2 variants that are out there circulating. And the questioner asks, certainly right now, HV.1 is the most prominent subvariant of Omicron. Do we think we'll see the BA.2.86 variant become a predominant variant in the United States over the next couple weeks or months or so? Currently, the suggestion from CDC, and this is based on immunosurveillance conducted across the country, the suggestion is that no, BA.2.86's time in the sun has come and gone, and that in fact there are other subvariants, and I'll name them in just a second, that will continue to occupy and take over the ecological niche, which is highly competitive SARS-CoV-2. Importantly, all of these subvariants, even the most recent ones, are different only in their infectivity perhaps, or their ability to participate in immune escape. And yet, the match between the current COVID-19 booster vaccines out there, especially Pfizer's and Moderna's, remains good, meaning that somebody who has received a recent COVID-19 booster or primary vaccine series for our patients should have adequate to good protection against all infection and good to excellent protection against severe disease with any of these subvariants. So there's enough, overlap between the immunologic reaction to the vaccine to protect against the subvariants. So what is out there, and these are the top 4. Yes, I feel a little bit like David Letterman's, top 10 list, but you only get 4. Sorry about that. Number 1 is still the HV.1, accounting for on average 29.6% of newly identified isolates in this country, here in the United States. Number 2 is the JN.1, accounting for just over 21% of new isolates. Number 3 is the EG.5, accounting for 8.8%. And the close runner-up, number 4, is the HK.3, accounting for 7.7% of new isolates. There is, again, those are the top 4. Our poor friend BA.2.86 is sort of suffering in silence, saying, "Well, I just sort of lost out." But that's not the worst thing in the world either. So more out of, I think, interest for what's circulating, and without any predictive trends from other parts of the world, those are the top 4 currently being identified here in the States and predicted to remain in the top 4 for at least the next several weeks. But importantly, and I guess very importantly, the disease associated with these subvariants of the Omicron variant of SARS-CoV-2 continue to be primarily upper respiratory. Adult patients, most especially, talk about a flu-like illness with very severe sore throat, malaise, high fevers, several days lasting, and still good responses in those who take this drug to Paxlovid, the combination protease inhibitor medication. Children, adolescents, when they are severely symptomatic, are still having the upper respiratory croup-like illness and or persistent dry cough, some with persistent fevers for 1 or 2 days or perhaps longer, but again, not typically significantly severe to cause a hospitalization. yes, for those of you who are practicing in urgent care and or emergency departments, and those of our colleagues who are, you're here to say, yeah, there's plenty out there of COVID-19, thank you very much. And you're absolutely right. It's out there. It is causing ED visits and sick visits for sure. But in terms of requiring higher level care, non-invasive ventilation, or even rarely invasive intubation ventilation, SARS-CoV-2 right now in pediatrics has not been a major bad deal. Thank heavens. We got plenty else on our plate for sure. So that does it for the questions for this week. Just other infectious disease notes from what's out there and circulating. There continues to be a higher than expected number of invasive Group A streptococcal infections, meaning Group A strep sepsis, Group A strep toxic shock-like syndrome. Certainly, the numbers of Group A strep-related diseases appears to have returned to pre-pandemic levels, meaning cases of strep pharyngitis, scarlet fever, and even more than a handful of cases of acute rheumatic fever presenting with a variety of the polyarthralgias, polyarthritis, or the carditis, or Sidham's chorea, or others of the like. And we talked a bit about this last time as well. So Group A strep definitely out there. So too are the sporadic bacterial pneumonias, typically following a preceding viral illness. The classic association is influenza A followed by pneumococcal pneumonia with effusion or empyema, and that makes sense because influenza A, with its neuraminidase and other enzyme actions, exposes sialic acid residues once it cleaves off new viruses, and sialic acid residues are exactly what Streptococcus pneumoniae recognizes to bind to respiratory epithelium. So flu A is a beautiful, unfortunately, precursor or risk setup for pneumococcal invasive disease, and we are certainly seeing cases of that as well. Several, at least in my hospital, several per week of focal pneumonia with effusions, some actually with persistent fevers and respiratory distress to failure lasting for more than several days. So Group A strep, strep pneumo, other bacterial sources of sinopulmonary disease, increasing numbers of mycoplasma community-acquired pneumonia. Yes, that's out there, especially in the adult patients, and therefore secondarily to pediatric patients in those families or with exposures. And mycoplasma remains, unfortunately, quite contagious among children who share airspace, share play toys, share bedrooms, etc. So it would not be unexpected to have several mycoplasma pneumonias in one family, just for those of you who may be seeing a cluster of cases coming in from the same setting. Other than that, yes, norovirus is out there, rotavirus as well, certainly for the rest of you in parts of the country other than Arizona, but we certainly have more than a couple sporadic cases, and certainly the norovirus has been reported nationally, and we're seeing plenty of those cases here as well. So that's kind of what's out there, folks. Thankfully, it's not tick season or mosquito season, so we can rest our minds for at least a little bit. Although, before we rest too easily, there in San Diego was reported a fatality from Rocky Mountain spotted fever acquired from a tick exposure in Mexico, in actually Baja. So keep your minds open for exposure histories for those patients with travel history, and don't completely exclude Rocky Mountain spotted fever from your differential diagnostic thinking. If you have a patient with unexplained fevers, a tick exposure, or a dog with ticks exposure, and no other explanation for the fever, at least consider Rocky Mountain spotted fever. You can test accordingly, and feel free to talk to a friendly local ID provider if you have any questions about next steps. So with that, thank you as always for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, many best wishes for a peaceful and safe holiday season. Hang in there, folks. I know this is when things get even more crazy than typical in terms of sick visits and crazy, anxious people just needing some support and reassurance. So I know that all of you are serving as your patients' rocks. Hang in there. Please keep fighting the good fight, doing the good thing. Know that we appreciate you at the chapter, and just hang in there. Happy seasons, everybody.